Good morning, everyone, and thanks for coming along to our Hepatitis Scotland World Hepatitis Day online video event. I'm Norma Westland. I'm the Programme Manager for Hepatitis Scotland. So it's been a difficult 16 months with global pandemics and whatnot, and it really has had an impact on what's happening in the world of hepatitis. The thing that I've been most struck by, I think, since coming into this post about 3 months ago, is firstly how hardly it's been hit. A lot of the staff that are involved in sexual health and bloodborne viruses have been taken away to kind of deal directly with COVID. But even more than that, I have been so impressed by the dedication of a lot of the staff that are involved and that have still been on the front line. I've been really impressed by some of the amazing practice, really innovative stuff going on out there. And today I want to kind of just showcase some of that to see if it can inspire others and to give people an opportunity to share their good practice. The programme today, so we're going to start off by listening to the Fife bloodborne virus nurses do presentation, a video presentation, and then we've got Gabriele Vojt, who's going to talk about some research that she's doing just now, the EpPIToPE project, and then Petra from the Hep C Trust going to do a presentation for us, and then we're coming back with our Lesley, who's going to do a workforce development and training launch. Afterwards, we're joined by Billy and Eddie, who are going to talk about some outreach work that's been going on in Lanarkshire, followed by Louise, who's going to talk about some test to change presentations that she's been doing in Fife. And then finally, we've got Nikki from Restoration, who's going to tell us a little bit about who they are and how they were set up and the amazing stuff that they're doing just now. We'll then have our closing remarks. So we will kick off with the presentation from the Fife bloodborne virus nurses. Thank you.
Hi, my name's Karen Thompson and I'm Senior Charge Nurse for the Bloodborne Virus team. It's my job to ensure that we as a team support patients from diagnosis through treatment and beyond. We're always looking at new ways to get in touch with people who are referred but don't make it in to see us. There are also a lot of people who are unaware of their diagnosis. In order to do this, we are working closely with partners to make sure all those who have been at risk are tested, treated, if needed, and cured. We will be visiting hostels, pharmacies, food banks and other areas in our mobile van over the next few months, so please look out for us and come along. When I started working with hepatitis C, the treatment available was interferon injections and ribavirin tablets, which often caused horrendous side effects. Nowadays, it's so much easier and really exciting to be able to treat and cure people with only 8 or 12 weeks of tablet-only treatment, which has very few side effects and could potentially eliminate hepatitis C from being a public health concern. It's so great to see the difference that getting rid of hepatitis C can make to someone's life, but also being in touch with the support services like Restoration can really help people to move on. I've already mentioned our mobile van, and I'm really pleased to be able to say that very shortly we are looking at being able to offer testing with results the same day. As you can imagine, this could mean that we can offer a test and arrange treatment on the same day for positive results. And I have to say that the thought of being able to do that makes my heart beat a little bit faster and puts a big smile on my face. The team makes it very easy to do my job because of the never-ending enthusiasm and desire to help that everyone shows 100% of the time.
My name is Anne. I'm a bloodborne virus nurse. I joined the team in 2015. I'm one of the staff who, due to the COVID pandemic, was seconded to test and protect for 8 months. I asked to return as I missed the team and, more importantly, the patients. We as a team have always been keen to use an inclusion approach and have now expanded this.
I'm Stacey. I'm one of the bloodborne virus nurses. I've worked here for 6.5 years. In 2020, when COVID hit, We cancelled all our clinics in the local communities. We realised that patients still needed to be seen because Hepatitis C can't wait, so we basically ordered backpacks, filled them up with stuff, and we went out to see patients. We chapped doors, we stood outside pharmacies, we walked up and down the high streets, and we found the patients that we needed to see. Hepatitis C treatment is a priority for us, but what we found when we went out to people's homes is that that wasn't always their main priority. We found that a lot of social isolation, patients were living in adverse poverty, they had comorbidities that needed dealt with prior to their Hepatitis C treatment, and a lot of patients were suffering. We joined forces with other agencies, third sector agencies and NHS colleagues, and we went out to these patients and identified what was the most important to them. We have been dressing people's ulcerated legs, we have been delivering food parcels, we have been getting people beds. For one gentleman has now slept in a bed for 7 years. We have dealt with what they feel is their priority, and the Hepatitis C treatment has came second to them, but it's still been done. We have been delivering treatment to patients right across Fife. We have used our mobile unit, we have been in our cars, we have done it through telephones, via hospitals, but the treatment still gets done. We, as the patients know, the treatment can't wait. We don't want to see these patients with liver problems in the future. So we will do whatever we can to make that happen.
Hiya, my name is Karina. I'm one of the bloodborne virus nurses here in Fife, and I normally work in a team of 4 trained nurses and 1 clinical support worker. Because of the COVID pandemic, 2 of our team were taken away to test and protect, which essentially left 2 nurses to cover the whole of Fife. We cover Fife bridge to bridge. Fife is actually quite a rural area, and all our outlying clinics that we usually would see patients in were all closed. To meet need, we changed the way we worked, and basically we put PPE on and went out into both lockdowns to identify patients needing treatment for Hepatitis C. They say that Hepatitis C doesn't wait, but and probably neither do we, but we do wait. We wait until you are ready for treatment, and we will support you every single step of the way in whatever you need help with. What I would say is true doesn't wait is that cirrhosis doesn't wait and liver cancer doesn't wait, and that is all we are really trying to do. We have no other agenda other than to help you and to treat your chronic Hepatitis C infection with a view to cure.
Wow, thank you so much to the Fife Bloodborne Virus Nursing Team. I just think it's such a powerful video. The theme of this conference, the World Hepatitis Day theme, is Hepatitis Can't Wait, as the nurses mentioned. With somebody dying every 30 seconds from a hepatitis-related illness, even in the current COVID-19 crisis, we can't wait to act on viral hepatitis, on reducing and eliminating. People living with viral hepatitis, unaware, can't wait for testing. Life-saving treatment, can't wait. Expectant mothers can't wait for hepatitis screening and treatment. Newborn babies can't wait for birth dose vaccinations. People affected by hepatitis can't wait to end stigma and discrimination, and there'll be a lot of talk of stigma throughout this. Community organisations can't wait for greater investment, and decision makers can't wait and must act now to make hepatitis elimination through political will and funding. So we're going to now move on to Gabriele Vojt, who's going to present some research that she's doing. She can explain it far better than I can, so I'll hand you over to Gabby.
Yes, so thank you so much to SDF for inviting us to talk at today's conference. I'm here to tell you a bit about a research study that we've been doing for the past 3 years with our bit, so the research team I work for, looking at developing recommendations on how to upscale different and various healthcare systems and pathways to deliver Hep C testing and treatment as part of their routine work. So I'll be giving you a quick background to what the study is, how it came about, then talk about the methods, what exactly we did, give you some of the results, which really is the recommendations and a Hep C testing and treatment pathway. And then there's just going to be like a wee summary just to sum it all up. And for anyone who's interested, because it'll be quite a bit, to ask questions there and then on the spot. So the research project that we've been working on, the full title is Evaluating the Population Impact of Hep C Direct Acting Antiviral Treatments as Prevention for People who Inject Drugs, EpPIToPE. It's funded by NIHR and it's a public health program. Essentially, I'm just here today to tell you about the qualitative work we did, so interviews and focus groups, but there's different and loads of different strands in this research program. So there is a quantitative strand, there's a clinical strand, there is a cost effectiveness, mathematical modeling strand. There's a lot going on, and the whole program is actually 5 years long. The chief investigators are Professor John Dillon from up in Tayside, Professor Matt Hickman, he's down in Bristol, and Professor Sharon Hutchinson, who's with us at Glasgow Caledonian University. The qualitative work is led by Professor Laurie Elliott and Professor Paul Flowers, who are both in Scotland. So the qualitative work is what we're going to focus on today. And I thought I'd just give you a wee bit of background. I mean, it'll be information you probably know, but about Hep C in general. So we do know it's essentially a terrible, debilitating disease. In 2019, 6.1 million people were diagnosed with Hep C. And we know that 40% of people who inject drugs are likely to get Hep C through the transmission rate. Now, the World Health Organization in 2016 essentially said by 2030, we want Hep C eliminated due to its massive impact on healthcare systems, on resources, but also on individual and personal lives. But how to do this? So international research suggests that if you want to eliminate Hep C, you need to implement testing and treatment across various settings, healthcare settings. So essentially saying you need to take the testing, the treatment to where people who inject drugs are, so where they hang out if you want. And I think as the nurses from Fife quite rightly pointed out, you need to take every opportunity, maximize on all opportunities to engage and test people. Now, we know that in Tayside, mathematical modeling suggests that this can work. If you take a number of different healthcare settings, such as pharmacies, drug treatment centers, and you implement testing and treatment there, you make it the frontline staff's job. This has the potential to eliminate Hep C completely. And EpPIToPE, our research project, really was just, well, actually, let's see if this works in real life. So EpPIToPE follows up a large cohort of people who inject drugs in Tayside, checks them on various occasions in terms of clinical data, clinical markers, questionnaire data, quality of life. And our project, our qualitative work, was all about if this works, if this does actually eliminate Hep C, how do you do that? What are the lessons learned? And what can we tell other people, other places, what they should do so that they can reach elimination as well? So in Tayside, essentially, in addition to delivering Hep C testing and treatment in your standard hospital setting, they also did this in needle and syringe, in pharmacy, in drug treatment clinics, and in the prison. Now, when I say needle and syringe, in Tayside, this is a wee bit different. It really is an enhanced needle and syringe setting, if you want. So it's not an add-on service or an add-on clinic that would run in a pharmacy. Rather, the needle and syringe program, 2 of them in Tayside, are really well embedded within a host of complementary therapies, if you want. So the Cairn Centre, I'm sure the majority of people will know about this, is within its own building. It's surrounded by psychological help. There's a cafe. It's a really one-stop shop where people who inject drugs can go in to get fresh equipment, but then can get loads of help, loads of advice, or just a really friendly word and have a wee sit down. Everything works really, really well. So what we did in our research was we focused on when needle and syringe pathways were embedded with other services, if you want. Now, the challenges in our research really were, number one, there's so limited knowledge on how you actually optimize or upscale a setting or a pathway. So how do you take an existing service and you add new stuff to it? And how do you do this in an evidence-based and in a systematic manner so that everybody really understands what exactly has gone on here? Furthermore, from a behavioral perspective, from a research and a psychological perspective, really, when you have a pathway, loads of things happen, and it's really complex, and it's multi-actional, if you want. So in particular, we were interested in who needs to do what, to whom, in what order, and why. So all of these different points have to be not only understood, but addressed, and then found recommendations that help others to meet these different points. And I think perhaps the biggest point, the biggest challenge is, you can have the most amazing upscaled service, you can have the greatest recommendations in the world, but if nobody follows them because they're either not seen as useful or relevant, or they're just so complex, policymakers, clinical leads just won't use that. So it's all about, well, how do you take your research findings and you make them actually practical so people do want to and end up using them. So to meet these challenges, we did the following. We essentially went to Tayside and we did a retrospective behavioral qualitative study, which basically means we asked people, what did you do? How did it go? What would you tell other people to do? And we did prospective recommendation generation. So we took Tayside's information, their knowledge, and we jiggled it into recommendations telling people this is what works. And if something doesn't work, then this is what you need to do instead. Now, there were 4 phases in our method section, which I think is really important because it does show you that the whole thing was really structured and it's auditable. You can see exactly what we did, how we did it, and what it resulted in. So it makes recommendations and it makes research findings absolutely credible. So first of all, we went to Tayside and we chatted to people who were heralded as experts to us. And we essentially asked them, well, what does your service, what does it look like? What's the pathway? Who does what? What do you think are the quintessential steps for this pathway to work? And we made, if you want, we made like a map or almost like a Monopoly board game. And you could see exactly what needed to happen when. And when we did our interviews, our formal interviews and focus groups, we took our wee map and we asked for facilitators and barriers at every single step. So we made absolutely sure that we covered the entire pathway. Now, most qualitative work probably stops when you've got your barriers and facilitators and you've got some absolutely cracking quotes. But what we then did is we took those quotes, so those barriers and facilitators, and we coded them systematically using a behavioral analysis framework. And what I mean by that, really just briefly is, you've got a quote, let's say it's a barrier where somebody talks about, oh, I can't do testing because I don't know how. So our job then was saying, well, what is actually going on here? So there's a theoretical domains framework, which looks at the causal mechanism underlying a barrier, which in the case of the quote I just gave, I don't know how to do this, this is all about skills. So what does that mean in terms of intervention? Well, it means you need to provide training. And the final step is identifying well-established and well-tested behavior change techniques that will achieve the intervention. So in terms of training, we're talking about essentially demonstrating to people how to do something, modeling how to do it, have them essentially shadow you, follow you around, have them practice. So very specific techniques, which then underline a resulting recommendation. And last but not least, we took all of our recommendations. So I'm not going to lie, we had thousands because they were so detailed and they were so specific. So we took our recommendations, narrowed them down to what we thought was essential, and then we checked every recommendation with our group of clinicians and practitioners in Tayside. Then we invited people from all over Scotland to give their opinion on whether our recommendations worked and would be relevant to them. And last but not least, we then went to England and we did exactly the same. So we were asking a different setting, different approaches, whether our recommendations could be transferred and the insights from Tayside, are they relevant to them as well? So it was a co-production process, which resulted in very specific, highly relevant and useful recommendations on upscaling Hep C testing and treatment in a range of different healthcare settings. But who did we actually speak to? So we had 40 service providers. That was all sorts of different people. We spoke to peer workers, team leaders, clinical leads. We had frontline staff. We spoke to the Hep C nurses who actually run the entire show. And we also spoke to service users. So we had 31. We had a couple of treatment delayers. So people basically saying, oh, I didn't pick this up, the direct acting antiviral treatments when they came in, because I was so scared from the interferon. There was no way I was going to do this. So we were trying to find out what was it that made you start the treatment? What was the treatment like? What would you say works? What didn't work? What would you change if you could? And really, this is what we did with all of them. Almost all of our service users were interviewed by trained peer researchers. So we were collaborating with the Scottish Drugs Forum on this. And we got some absolutely cracking interviews, which without a shadow of doubt were better and richer because it was done by peer researchers rather than, for example, me. So in terms of the results then, the recommendations, what we did was we looked at every single one of those healthcare settings. So as I said earlier on, enhanced needle and syringe, drug treatment, prison, and the pharmacies, that's right. And we found 27 recommendations, which we believe apply to all of these settings. And then per setting or per pathway, we identified a couple of essentially highly specific relevant recommendations just for that setting. So I'm sure everybody will agree. If you're a service user and you go into a pharmacy, and you're being approached by your pharmacist, or really any pharmacist, who wants to ask you, the service user, whether you'd like to get tested and treated for Hep C, that's very different than if you pop into a needle syringe program, because you're there for a very specific reason. You just want probably your stuff and then you leave. And that's even more different from the prison, where really the worst thing to do in a prison is you're identified as a Hep C, potentially a Hep C positive person. So we found loads of differences, but we found enough similarities to have these shared recommendations. We divided them into 4 different groups. So we took the World Health Organization guidance on this, and we basically put our recommendations along access, testing, treatment, as well as support during and after treatment. Sorry. So all of our recommendations essentially map onto this pathway that we established. And I know that this is probably very overwhelming, so I just talk you through it. The first box here talks about access. So first thing that needs to happen is a service user, a person who injects drugs, enters a building, enters a service for whatever reason. At this point then, this is the first visit, a frontline member of staff, or if you're working with a Hep C nurse, approaches them, initiates the conversation about Hep C in a really sensitive or in a way that they know is going to work. Get the service user into thinking about testing and treatment, and if at all possible, does the testing straight away. So basically get them hooked, just get it done. Now we found that if you're in a setting where you have point of care testing, so you have like a gene expert machine, essentially the entire pathway stops here. You've got your testing, you get it done there and then. During the first visit, you get your results and you can initiate treatment, job done. But if you don't have access to point of care testing, and essentially it's your job to try and get people stay in the pathway or stay in a pathway that is related to you. So for example, you need to send off your service user for further Hep C testing, so getting the bloods, but also getting a history, making sure the liver is okay. So that might be in a different setting. Then they have to come back to you because you need to give them the results, and then you start your treatment and you initiate this support to keep them with you, to make sure that treatment is seen through. In terms of ongoing support, we found that essentially in Tayside, all the meds were picked up from your local pharmacy. And we found that pharmacists had a massive impact. If they were on the side of service user, if they engaged with the service user, made them feel like, I'm really interested in you, I want to make sure you're going to be okay, and I totally believe in you. This just worked. This was the main point where treatment adherence appeared to happen. We then found that the SVR test, so basically the test of cure, was also another required visit, at which point you essentially dived into wider harm reduction strategies and made sure that your service user understands this isn't the end of the road. This is essentially about keeping the person safe and healthy and keeping them in the pathway if you want. So identifying reinfections through this ongoing support and through continuing testing. So all of the entire pathway essentially feeds into one another. And we found that if this pathway, you can essentially adjust it to your own setting, but if settings collaborate, then you've got service users who can do pathway or setting hopping as much as they want. Everything works together and it's a smooth process. So just a wee bit about the recommendations. Now, I should say at this point, we've got them done and dusted. They're all ready and we are wanting to disseminate them as widely as possible. We would love to hear what people think, but more importantly, use them because we think they're really good. None of them are, I think, surprising. There's a lot of stuff that makes total sense. We got that feedback from all of our stakeholders, but I think it's helpful when you know it comes from a research study that uses evidence, that is structurally sound, and has received loads and loads of feedback from stakeholders across the UK. So in terms of access, we found, I'm just going to talk about 3 top ones, that a nurse-led model is absolutely crucial. It's crucial, not only in terms of resources and finances, but in terms of engagement, keeping a service user in there, but also making sure that different settings, different pathways work together if you want. Co-location is another massive one. And I mean physical co-location. So that could be having a Hep C nurse working directly with you and having clinics with you in your setting, or indeed co-location in terms of having loads of different services together, like the Cairn Centre in Tayside, where you've got this one-stop shop going on. It's really, really, really crucial. And we found peer workers change everything. Peer workers in terms of having discussions with service users, getting them into a state of thinking about Hep C, considering getting testing, considering speaking to service providers was absolutely massive. Peer workers were outstanding. In every single setting, and stakeholders were saying, no, peer workers is the way forward here. In terms of testing, we found that this is not just about Hep C. It makes absolute sense if you embed Hep C within a wider testing strategy. So if you actually manage, if you get an opportunity to test someone, you might as well put in HIV Hep B testing. We found point of care testing. Everybody wanted it. Everybody thought this makes everything so much easier, including service users. So we also had a stakeholder event with them. Now, staff were saying that can be really expensive, and it depends on the size of the health board or the clinic you're working with. But it is the future. And training of staff, we thought, was really, really important. There's a massive difference in telling someone that they're Hep C positive and that they're not Hep C positive. So sharing these results when you're frontline staff, and for example, you work in a pharmacy and don't really know how to do this because you haven't really ever done this before, can be really tough. So we thought training really needs to happen here. In terms of treatment, we thought it was basically treatment and support really work well together. It's about how you keep that person in treatment and you help them to engage with the treatment and keep on taking it. It was a mix of having like a Hep C facilitator. So this was not only for the staff, so that everybody knew what was going on, especially if a service user was hopping about in different settings, but also in terms of having like a verbal agreement which very often happened in pharmacies, where the pharmacist would learn what to say to a service user to keep them going and to get them on board, and to essentially its implementation intentions to get them to commit. There are some really, really cracking training initiatives in this. It really does work. We found that an admin sort of database in Tayside, this is being run by the Hep C team, again, changes everything, because you know who your service users are and you can track them, and you know whether they're PCR positive, and you know when they got tested, when they got treated, and when the next testing has to happen. So just to sum it up, because I've been talking for a long time, I think, all of our recommendations are evidence-based and they are theoretically informed. I think the great thing about our recommendations is we've test-driven them with a range of stakeholders, and we got great engagement, we got really good feedback. What we did was we took if you want, like a chunk of recommendations to each stakeholder event, and then we asked our stakeholders whether they think we should kill, keep, amend, or add to a recommendation. So it was proper co-production in every possible way. And as I said early on, we then took them to England, completely different systems, in particular when it comes to pharmacies, and asked, can you use that? Does this, or does it ring true with what you're doing already? And I should probably also say at this point, we know that these recommendations are linked to quantitative data that suggests upscaling absolutely works. So perhaps people are aware that in July 2020, the team in Tayside announced that they had eliminated Hep C by 90%. So they were well on their way of meeting the World Health Organization aims. We don't really know in terms of reinfection yet, so that data hasn't been analysed and published, but it is looking like really, really positive and really promising. But I think at this point, I'm just going to stop speaking. If anybody has any questions now, I'm here. Otherwise, of course, at the end of this conference, or please email me, and we would be absolutely delighted to give you more information.
Thanks for that, Gabby. That was really interesting. If people could put any questions into the chat, that would be really helpful. One of the questions that we've had was, did you meet any resistance kind of on the way?
Oh, can I ask resistance in what way? Like
either from services or people using services, or generally, was it a really positive experience?
We definitely found that different settings had embraced Hep C testing and treatment at different points, and it was working well in some areas, but not working well in others. So I don't think this is anything new, but for example, in prisons, there's loads more barriers than, for example, in an enhanced needle exchange program, if you want. So there were definite differences, and we found that especially the barriers in prison, apart from the fact that you're in prison and everything is, well, timed and scheduled, apart from these structural barriers, there was a definite people not really working together, and it is the whole, everything comes back to test at every single opportunity, engage people whenever you can. And we found that in prisons, and there was also some issues with drug treatment, that this just wasn't necessarily their priority, and they were looking at other things instead. So that we found that, but we did find that staff were open, and they were just saying how it is. Service users were great. They were also saying quite clearly, this is how I feel, this is what works for me, this doesn't work at all.
I can't, personally, I think like I said, it's such a good piece of research, and I can't wait to see it rolled out. I'm going to invite Sophie on. Sophie has a question.
Yeah, so I'm just looking at the chat right now, and so we've got a couple of questions in. And so we have a question from Petra from Hep C Trust. How does the announcement to move to Buvidal monthly with no pharmacy involvement affect the pathways?
I'll be totally honest with you. I can't answer that question. I would love to look this up, speak to my supervisors and get back to you.
And so we actually have another question as well, and that is, could the multiple tests and strategy be expanded into forthcoming long COVID treatment centres and co-join promotion of Hep C and HIV?
I think that's such a brilliant idea. So it's got to be said, our data collection, so in particular speaking to the staff, had practically finished just in time for COVID to knock on our doors. So we were a bit like, oh no, this is all outdated. But all of our stakeholder events happened during COVID. And there was essentially people not only talking about, this is all I do now, COVID, test and trace, but we had follow-up interviews with the Hep C staff in Tayside and found that and I'm sure loads of different Hep C teams found ways of just jiggling these two together. So when you go to someone's house, you do your COVID test and trace and you talk to them, you chat to your service users, you just slide that Hep C or HIV and Hep B right in there. So it absolutely works. I do believe it comes down to, but maybe that's me, this is me being a bit too psychological, but I think it does come down to what's your relationship to that service user. How far can you push there? Or perhaps just how good are you at blethering? But I think it's a brilliant idea. That would be fantastic.
Yeah, I think that therapeutic relationships, it's vital, especially when we're talking about highly stigmatized people, and I think just making people feel welcome and warm, and for people to know that you're there for them makes a huge difference.
We did, so I haven't really talked about this, but we did a little follow-up study. So we interviewed 30 service users 12 months after they had finished their Hep C treatment. And one of the questions we were like essentially just tapping into, again, so what was it that made you start the treatment in the first place? And how did you stick to it? And how are you now trying to keep yourself safe? And the overwhelming, like the biggest theme is really because the staff who keep you on board, they're not just staff for service users, they're like family. They're like the only people who seem to believe in them and actually want them to see doing well. And it was just, I don't think it's surprising, but it was so strong. It was repeated so many times. I think one of our recommendations, and we were trying to be diplomatic about it, but really is recruit staff where they can do this. They can make people feel that way and keep that staff in the job. So if you have to sweeten that contract, but keep them, because it makes all the difference.
Yeah, absolutely, completely. And that's what I kind of wanted this event to be about. It is about celebrating those staff, because they're doing a lot of amazing work out there, and it's not seen, it's not recognised. They're not bragging about it in the way that some services do. And I think I really wanted to kind of spotlight the good work that's going on. Thank you so much for that, Gabby. I really appreciate you taking the time to come in and present to us. And Petra's going to join us now. After Petra's presentation, we're going to have a break, but I'll hand you over to Petra.
Yeah, thanks, Norma. My presentation's brief. It's called Working Towards Elimination in our Scotland office. I'm going to begin by saying that we're all involved in achieving the Scottish Government's target elimination by 2024, and we're part of a global effort for elimination by 2030. So let's hear a wee bit for the World Hepatitis Alliance about the wider picture.
In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. We have the power to eliminate hepatitis and save 1.1 million lives each year. It's time to act. Hepatitis can't wait.
Okay, so we all know that during COVID, services virtually stopped up here in Scotland. IEP services stopped in many places as all the staff were redeployed, as you've heard earlier. People in Public Health Scotland themselves working on bloodborne viruses were also redeployed because of the pandemic. But now, this slide will show you where Forth Valley is currently. We have a small project up here. My colleague Jim is the peer support lead. So this is his current sort of caseload. He's got 21 clients supported. 5 of them are actually on treatment at the moment. 11 are through treatment and waiting for their SVRs. And then there's also the support beyond SVRs. As it was said earlier, what we find is that tackling the hepatitis C and taking that first step to addressing health issues can actually lead to better engagement for other things, pre-existing conditions. I know one chap, there was a sort of cancer scare, and you know, Jim will quite happily stay with them because that trust has been built, and take them to appointments even after they've got SVR. New diagnoses just came through. We've had 5 referred to us. Most of our referrals will come from the BBV team. And usually what Jim's finding is that I suppose you could classify them as the more difficult patients to see through the pathway. So they really need quite a lot of work, encouragement and trust building. And I'll give a cone to anybody that notices my deliberate typo down in the bottom right. It should have been Beyonce's SCVR report, but never mind. So this is, because there's only Jim and I up here in Scotland, we're part of the Hep C Trust's North team. Now, the Trust have expanded from my day when there were 6 or 7 of us to over 90 people now. They're helped by Public Health England's deal with the pharmaceutical companies to provide case finding as well as the drugs to treat the cases with. I suppose it boils down to, you can have the cheapest drugs in the world, but if you've got nobody to give them to, then kind of defeats the purpose. So here we've got Scotland against the North team, Newcastle being the largest one there. Now they get referrals from CGL. They've got an information sharing agreement with CGL. So basically, they take the kind of load off, you could say. CGL provide a list of clients to our peer leads to go and chase up whether they've already been tested positive and not engaged with treatment, or on their books and still haven't been tested. So there's a lot of collaboration between the 2 services. Also, I think Humankind down there and Hep C U later. There's a whole lot of people involved in the effort. Next slide, please, Sophie. So we see the treatment starts per area, and this is over the pandemic. Now, a lot of that was down to having access to the homeless people housed in hotels in the early pandemic. And also, it's basically the joint working that's happened between the services down south have really made a difference. A lot of them have, as you heard Gabby saying there, the EpPIToPE machine, the point of care testing, and that makes a huge difference. Apparently in Liverpool, that is essentially their first-hand go. And they're quite happy to use pan-genotype medications to get people on treatment on the same day. So this sort of lays out quite clearly, I would say, the causes of the pandemic and what it's done to services, especially here in Scotland. If you look at the early months of the pandemic, April right through till October, virtually nothing happening up here. picked up in November a bit. Things were easing a wee bit, and then of course we have lockdown, Christmas, and we are beginning to pick back up again slowly and surely. If you contrast that with what was happening just over the border in Newcastle, because of the point of care testing and all the help that they were given, and the collaboration between everyone, they managed to keep going even during the early days of the pandemic. So they're well on their way to reaching elimination, I would say, as a country. As I said, it's all about working together. Here in the Forth Valley, we've got a small project running, but we work with us, the CGL, Transform, the Recovery Community, Salvation Army, Homeless Services, the NHS, self-referrals, and a bring your pals routine, you know, if possible. If Jim can convince them to, you know, my brother, actually, would it be okay? Could you come to the house and maybe test him because he works all week and things like that. But it's the only way that we're going to actually get out of this and reach elimination. And the other thing to remember is that we can't treat our way out of this problem. What Gabby was alluding to was the whole package. Injecting equipment provision needs to be beefed up. The two things are intertwined these days, because the majority of people now are people who use drugs. We can't be lost within the drug deaths crisis. It's an equal. It takes longer to kill people, but till it does. These are just some pictures of our teams out and about doing the road with their excellent equipment. You know, they've all got special vans and gene experts. And next slide, please. This is Barnsley. They did 198 tests within 2 weeks, so that was a good result for them for one test and trace thing. Could we go to the next slide, please? Royal Liverpool, as I said, they're using Gene Expert largely, not exclusively, but largely to get through it. The next slide, please. And these are West Yorkshire, part of our North team, who won the UK Parliamentary Health Equalities Award just a few weeks ago. I hope you enjoyed that, and if you've got any questions to ask me, please do. Thank you.
Thank you so much for that, Petra. I mean, you and Jim are doing outstanding work, but you can't help but feel a little bit like the poor relation in it all, you know, when you see what's kind of going on down south, and the difference a bit of investment can make. So I'm going to move on, and Lesley Bon is going to talk about workforce development and training.
Hi everyone, and yeah, thank you for having me today, Norma. Today I'm going to be talking about a learning needs assessment our team did for the sector, just a little preview of the results before we launch our new training. So about 10 minutes with me today. So a little bit about background about our team. SCF was awarded 3-year funding in 2018 from the Sexual Health and Bloodborne Virus Framework. This obviously finished in 2021 during the pandemic, where there was 1-year continuation funding awarded, taking us up till next year, when we assume there'll be a relaunch of the framework. The remits that our team have under this funding is working to create training and opportunity and development around HIV affecting people who inject drugs, vulnerable young people, and specific populations at risk of poor sexual health and bloodborne viruses. Those populations are people involved in selling or exchanging sex who use drugs, men who have sex with men involved in chemsex, and people who use steroids and other image and performance enhancing drugs. And as part of the 1-year funding, we were asked to do a training needs assessment of the sector. So the training needs assessment that we did, first of all, we had some discussions with frontline staff around people's capacity and the merits of a shorter assessment using Microsoft Forms and a longer assessment, maybe doing interviews, for example. It all came back to us that people really didn't have the time to commit to longer interview style assessments. So we opted for a 10-question survey on Microsoft Forms. And we distributed it via our networks. And the survey was live during the month of June. And we got 278 responses collected. And the following is just a little preview of those results for you. So responses by area, NHS Tayside coming strong with 24% of responses, and NHS Forth Valley with 20% of responses. See their Greater Glasgow and Clyde 18% and Lothian 10%. We also got almost 50% of responses were from the third sector, 26% from NHS and 25% from local authority. So a really good spread from the different sectors there. We then asked people which field they worked in, supporting people in. And here people could multi-select across all the different options. So that's why the numbers total more than 278. You can see substance use for drugs is the largest response with 152 out of 278 responses, 137 responses working within the alcohol sector, 71 responses from mental health and 62 housing and homelessness. So we wanted to know what percentage of people felt knowledgeable around certain aspects around bloodborne viruses. So here we're showing responses for bloodborne virus transmission and prevention. Almost 50% of responses said that they felt knowledgeable on this subject, that transmission and prevention of bloodborne viruses was something that they were knowledgeable in. Just under 10% of responses felt that this was something that they had little knowledge in. So a little bit of work to do, but fairly good, given that almost 90% had either some knowledge or felt very knowledgeable in this area. Knowledge then actually decreased when we came to talking around bloodborne virus testing and treatment. You can see that people that had little knowledge, this increased from under 10% to around about 15% of people felt that they had little knowledge in testing and treatment of bloodborne viruses. Just over 40% of people felt that they were knowledgeable, and just under 40% of people felt that they had some knowledge in this area. The next topic that we asked people to state their knowledge in is an area that we're really here to focus in today, elimination of hepatitis C. And it's one of the areas that staff in the sector felt not as knowledgeable as the rest of the topics. So you can see here that over a third of people responded that they had little knowledge around Hep C elimination efforts. About a third of people, they had some knowledge, and about a quarter of people felt knowledgeable. So it's a real area for workforce development. And then the final topic that we asked people around the causes and effects of stigma, and I'm really, really happy to see that this is the one area that staff felt fairly confident in, that they understood the causes and effects of stigma. Seeing there that almost 70% of people responded that they were knowledgeable in this area. Given that stigma is one of the biggest issues around access to testing and treatment for bloodborne viruses, it's good that we can build on that work. Here we then went on and asked people how confident they were around certain aspects that would be within their roles. So the first two questions are all about either asking people about how they're injecting or providing people with safer injecting advice. And actually people felt more confident to ask people around their injecting practice and what drugs they use and how they use drugs, but they actually felt less confident to provide advice around safer injecting and drug use. And that's actually the opposite when we look at sex. So staff felt less confident asking people about the sex that they have, but more confident to provide people with safer sex advice. So there's definite work to do to increase confidence around all of these areas. Really, we want to see these areas all going within really confident. So definite work to do, but I thought it was an interesting to see that this is actually flipped. One, asking people about what they're injecting compared to asking people about the sex that they have and providing the safer the harm reduction advice that follows. So what is really good is that we have all these results. We also got a lot of really, really good quotes from respondents, and given that we've not really done the full analysis yet, we've just pulled out some that we thought would be of interest to you. So the first one here, for the workforce, more and safer injecting practices for sure. This is such an under-resourced area and could prevent so much harm. Another person stating that they wanted more training on Hep B, C and HIV, especially access to treatment and how it works. And that was showed in results that it was one of the areas that people felt less confident in. Challenging stigma and resulting discrimination faced by people who use drugs, including links to BBV status. And although that we asked around that people understood how stigma, the causes and effects of stigma, maybe we could have asked if people felt confident to challenge stigma, and this could be something that I think that we could build into this sector training as well. And finally, I'd like to see more thorough training given to all student nurses and doctors and upskilling health professionals and BBVs. I think it's a really sensible suggestion there from people. So just to build on from the workforce development survey that we did, we are now today, it's live at 11 o'clock today for booking on. We have a brand new half-day training session created by SDF and in partnership with Hepatitis Scotland, and it's called Eliminating Viral Hepatitis in Scotland, where we will be taking people through hepatitis B, but mostly focusing on hepatitis C, prevention, testing, treatment, and also the elimination of viral hepatitis in Scotland as well. So we have 4 new dates launching right now on sdftraining.org.uk, and 2 dates next week around World Hepatitis Day. So World Hepatitis Day is the 28th of July. So the first training session is on the 27th, the second is on the 28th, 4th of August, and then 6th of August, the next again week. All the training is 9:30 until 1 o'clock. We will release more dates, but this is just the first suite that we'll do. We'll then look at evaluations and look to continuously develop and improve the training. All our training that I deliver, I do a maximum of 12 participants, and we do a range of presentations, group work, case studies. So it's not just listening to me talking for the entire time. And it's always co-facilitated as well by a colleague. The aims that we've come up with and learning outcomes for this training: increase workers, volunteers and community members understanding on key issues related to Hep C, with a particular emphasis on prevention, removing barriers to treatment and reducing stigma. It's not just for frontline workers, all members of the community and volunteers can have access to our training, and it's free to access as well. And the learning outcomes, I'll just bring them up for you so that you can see. So recall transmission routes, prevention strategies for Hep C, and be able to describe different testing methods and treatment options available, gain an understanding of the barriers people are facing, accessing testing and treatment services, and the different pathways that are available. Definitely be using some of the information that Gabby presented on earlier today. Discuss the causes and effects of stigma experienced by people affected by hepatitis, and also to feel confident to be part of the elimination efforts, that we all have a role to play for the elimination of hepatitis C in Scotland by the Scottish Government's target of 2024. Another thing that I would really like to ask is, we want to showcase examples of good practice from around Scotland. So if you have really good examples of engaging people in testing, linking into treatment, I would love for you to be able to send them to me and get in contact, so I can share them with participants that come on the training, and we can all just share the good practice that exists. So really, I think that's it for me. Please get in touch if you've got examples of good practice. Yeah, thank you. Also, watch out, in a couple of weeks we will release a report on the wider learning needs assessment. Thank you. Norma, pass over to you.
Thanks for that, Lesley, and hopefully you'll all kind of subscribe to it. It's really interesting, really interactive. I think you'll get a lot from it. So I'm going to now move on to Billy Hamilton, who works with me at Hepatitis Scotland, and we're going to show a video of an interview he had with Eddie in North Lanarkshire about some outreach work that they've been doing during the pandemic. So I'll pass you over to Billy and Eddie.
Hi, I'm Billy Hamilton. I work for Hepatitis Scotland, and introduce you to Eddie here.
Hi, my name is Eddie Vojt and I work for Positive Sport. We are with you as an assertive outreach worker.
So, Eddie, the purpose of this discussion is to look at how you continue to have an assertive outreach service during a pandemic. So, could you explain what your role was before COVID?
My role before COVID was to do outreach, find people it's hard to reach in wee pockets of communities in the North Lanarkshire, which is quite a sparse area, and get them tested and linked into the new treatments that started, and support them through that process.
So was that predominantly people who weren't engaging with services?
Yeah. Yes.
How do you think COVID's affected your ability to do this? I mean, what's been the main barriers for you?
Well, the main barriers was lockdown itself. People weren't allowed out in the street, and when they weren't allowed out in the street, addicts and alcoholics and people it's affected the hepatitis C were getting stopped with the police and getting fined. So it was quite hard to find people. So what we had to do was we had to think outside the box and contact them with phone, internet, use internet, online contact and support. And we found we got a lot more appointments in.
Right, okay. So was the treatment available for people during COVID? I know it's different in different areas, you know what I mean? Some areas have kept it going, others there's been no treatment. I don't know what yours has been like.
No, the treatments weren't available because the clinics had to shut down because of COVID, but near the end of the lockdowns here, they've started working again, they've started opening up and people have been assigned appointments and started back on their treatments.
Right. Did you have any issues with, I know certainly the area I used to work with, a lot of people moved posts because of COVID as well. So.
Shut its doors, people were allocated to different posts then, and then it was quite difficult to get them back on board to do the jobs we were originally doing because of how overworked they were through the COVID stuff.
Right. So obviously there's been a huge reduction in people getting tested, and I'm just going to say, have you found any other ways to engage? But you probably answered that. You're saying yeah.
What I did do is my current clients, I engaged more with them, but we also helped friends of friends as well. They were letting us know what their friends were needing, a bit of support and a bit of help, and what we've done is we've linked in with them, made appointments to get them tested once things open back up, but we supported them with food parcels, online stuff, phones, to help them communicate and get a wee bit of support through recovery communities and stuff like that in other organisations.
Right. So do you think that your role's probably expanded into working with different agencies now than before, like housing or DWP or like people's issues rather than their actual treatment?
Yeah, partnership working was a big major thing for us once the testing had stopped because of the COVID, and then we built up right good relationships with different organisations, housing, addiction teams, doctors, ART teams, North Lanarkshire Recovery Communities, Phoenix Futures, and that kind of made us closer, and we worked together and we linked different people, and it was a good opportunity for people to get extra support. Department work, pension, housing, it all kind of worked well.
Do you think services have worked better together during COVID or tried to?
I think we've came together a wee bit more because a lot of it was working for house and it was online meetings we were having, and that partnership working kind of grew through the online meetings, and it got other organisations knowing the kind of work you're doing and the impact you're trying to have in the community, and they came on board with it.
Which I suppose sort of kind of spreads about the BBV agenda really. All right, people kind of get tested, but you're dealing with the issues that they've got before they get tested. I was just going to mention, and you were part of it, in the research we've done for the conference, a lot of people has been through treatment, like their health determinants, their mental health, their physical health, their drug and alcohol use seem to go down, and better relationships with people and integrating in the community better. Have you noticed that with people that's been through treatment?
Definitely, they're more positive, more confident about themselves. Their self-esteem's a lot better, and they're able to make good choices, good positive choices. A wee bit of guidance, a wee bit of support, and a wee bit of belief in somebody, it makes all the difference, and it changes their outlook on life. So it gives them a wee boost that they're looking for.
Aye. I suppose the other side of it is when treatment's not been available. Have you noticed, MD, that you have been able to work with, any increase in physical or mental health issues, or drug and alcohol use going up, or
a wee bit of both, to be honest with you, but the mental health part, it was quite major, because they're isolated in their house. They can't get access to their old associates, they can't get access to their dealers and stuff like that, and people are usually running about, so they feel quite demented, closed in, and that's where our support came in. It was about trying to keep them motivated, keep them positive, help them with any issues such as Department of Work and Pensions, housing requests, doctor's appointments, food bank vouchers, online stuff, plus telephone. But I gave out quite a few telephones so they could stay connected to people.
Aye, and in my experience, all that good work will come back. When testing and treatment is fully available, people don't. Well, my experience means people don't forget that you've helped them out, and it's building up relationships. I suppose that's what I mean.
Yeah.
So just to say, now, who knows what's in the future? Are we opening up? Are we hitting a third wave? I don't know. But we'll try and look at the positive side. What's your plans for the future? Kind of working going forward?
I've got really positive plans for the future, and I'm feeling really motivated and excited about the stuff going ahead, because we're interlinked with a lot of more people. I've just opened up a few tower blocks. I've got premises in the tower blocks where I'm going to be supporting people up there.
Because we were doing some joint work before COVID. Was that the same tower blocks then?
No, that's different ones. Before COVID had struck, I'd already had premises for 5 different areas: Airdrie, Coatbridge, Motherwell, Wishaw, and Cumbernauld. COVID struck, we couldn't do anything. Our hands were tied. After the lockdown has came through, I've managed to open up premises in Coatbridge. I'm looking at somewhere in Cumbernauld just now, but the Coatbridge one I'm feeling really hopeful about. It's going to be coming down in a couple of years' time, but there's work to be done up there just now. It's about 60-70% full. Most of the occupants have been rehoused, but a lot of the people up there are still caught up in active addiction, and they can't get rehoused because of different issues such as mental health, unruly behaviour, ASBOs, all that kind of stuff. So hopefully we make an impact on that and get them signposted into the right help and support that they're needing.
That sounds good. So you've got a flat in the tower block, and you can signpost people on, you can get them tested in the tower block, and you're just there for a certain period of time, and then you move on to another one. Is that how it works?
Well, I'm hoping to divide my time. I'm hoping to spend 2 or 3 days in that one block. I've done a flyer distribution around all the towers to let people know I'm there. Once they've made a good impact in that, and there's not that many people, we've covered most of the people in it, and then we can move on to something else. Hopefully Cumbernauld, further out in North Lanarkshire.
That sounds a great idea. That's me, Eddie. Thanks a lot. Thanks a lot for chatting about what you've been doing and what you're doing in the future.
Thanks to Billy and Eddie for that, Eddie. It's really good to kind of see the work that you've been doing during the pandemic, and Billy and myself look forward to working closely with you in the near future. It's time to move on to Louise Bowman, and Louise is going to talk about 3 tests of change that she had done in a local area. So again, really interesting. So I'll pass you over to Louise.
So I'm going to do a wee presentation just on what's called test of change in the field. So I just like to call it get things done. But what happened when we went, Lesley and I, who Lesley presented earlier, we're national trainers for Scottish Drugs Forum and research and we do research and development. So going into lockdown meant we were put, like, having to work from home. And MD that knows me knows that I don't like to sit still, I don't like to shut up. So I was grateful to be invited to the new Fife inclusion team that Mark Stephen put together. He just felt that, you know, we needed to be doing more to reach people would be for around hepatitis C, sexual health, etc. And it was probably a group of some of my favourite humans and some of those real can-do attitudes. So with that, we got things done. So I'm going to present 3 tests of change that happened over the last year and whether they worked or not, and just some ideas for how other people can do things in the future. So like I said, test of change, or let's just give it a go. I like to kind of just jump in with 2 feet. People call them plan, do, study acts, plan, do reviews. Sometimes there's very little planning in what I do other than, yeah, let's do it. Anyway, what happened was in the start of the pandemic, lots of services couldn't meet face to face and they went, and everybody was all of a sudden online. The SRC, Scottish Recovery Consortium, had given local recovery communities a load of phones, but they were pretty quick to disappear. And we were sitting at the inclusion team meeting and, you know, somebody's going to have such and such had a phone. And I was like, I've got spare phones here, actually. And then we were all like, everybody's probably got a couple of old phones kicking about. So one of my old volunteers, she was able to put, she was really good with IT and was able to ping phones back to the beginning, only Androids. Telling you what I don't know about what I don't know about pay-as-you-go phones is not worth knowing after this. So what happened was we just put a call out to donate phones, and smartphones I meant, although we must have got like about 100 relics in that lot, and that included, if anybody remembers, BT Cellnet, Orange, T-Mobile, maybe that's still on the go, I don't know. Anyway, these were ones with SIM cards way beyond the size of some phones these days. So from about 100 phones in the first few weeks, we managed to probably get about 20 that were working, but we were able to fix screens and everything as well. And if people had broken their own phone, they would get that fixed as well, free of charge. So it gave one of my volunteers a wee bit of income as well. So these who all benefited. So when we're looking at people who are really disconnected. Not going to read everything all out. One of the inclusion team staff, Andrew, would take phones up to the prison so that people had a phone to come out to, and other people so they can connect with their parents in prison, etc. The other smart thing I thought I did a wee bit was when I was working for the peer research project, I tested a few people as hepatitis C positive, and I knew they hadn't still undertaken treatment. So when they came looking for phones, I told them to come up to the clinic to get them, and just by luck along came a nurse and started talking to them. So one person had commenced and finished treatment in that period as well. So I guess it's looking for all those sort of opportunities. Just to summarise, the cost effectiveness, when we added it all up, you're cheaper just buying phones. That's the long and the short of it. We had periods where we had lots of phones, periods where we had no phones. We were, you know, this supply and demand and the pressure on one person to fix all them as well. And also Connect Scotland came out too. So that Restoration will talk about it later, but they make it standard for everybody to get access to the internet and making it a Connect Scotland referral so that somebody can get sometimes a 3 years Wi-Fi and a device as well. I think that's all that didn't really work as well, but yeah, so basically just buy a phone and get it delivered. Okay, number 2, my Smears for Fears project. Now, I'm not going to talk about the outcomes for Smears because we're actually saving all that for an event on the Sexual Health Week, I think, a webinar there. What the project, this started to take shape before lockdown. We'd been interviewing females who used drugs and females who had lived experience of using drugs, and we found out that very little had been up to date with their smears, if even had one. So anyway, what we did was Sue Breacon at the Sexual Health Department, part of the Fife Inclusion Team, was able to secure some money to meet the needs that the females said they had to get to the clinic, so to get transport and to get some incentives for coming. What happened was I had a load of names to phone, people that hadn't had smears. Anyway, every time I phoned them, every phone call I made, I don't know why I can't click on the next bit. Well, there we go. Every phone call I made was about 40 minutes long. The level of unmet need out there was absolutely unbelievable. You know, people were dealing with real immediate crisis, but also longer term trauma crisis as well. So I asked Restoration, have you got somebody that can maybe come and help me with this project? And they sent Shauna. Shauna was my sidekick. She was an absolute godsend. She was delivering a women-only group at Restoration with Charlene, but she's also doing just finishing off her diploma in counselling at college. And I think that for me, the benefits of having peers there that Gabby said about, Billy said, Petra said, and again, Nikki will say again, is just the additional benefits you bring. The longer you work, the more away from the client group you get in some ways as well. So you forget about these. So I'm going to try and do this. The importance of peers, the new approach now, again, like Gabby said on her follow-up, when we followed up everybody that came for the smears, the reason they came that day, we only had one DNA out of 28, and the reason that people came was because of the friendly voice at the end of the phone. So Sean and I were phoning through people. We then used that opportunity to test people for bloodborne viruses. We also used the opportunity to treat people or get their livers scanned or their SVRs done if they had, if they needed that updated, and also opportunity to vaccinate for hepatitis B. That gained a bit of traction on Twitter, and we got new partners, and that was the criminal justice, Fife criminal justice team, who couldn't work with women that they would normally work with on a one-to-one basis. So they really benefited from it as well. And Shauna obviously was speaking to them in the waiting room a lot of the time, and a lot of disclosures were coming through. We were able to sort out lots of not just unmet basic needs, but some about getting access to their children and some about getting access to advocacy or even lawyers and stuff as well. So we were able to sort of connect things in. Shauna would invite people to the women's group, women only space, but it wasn't for everybody because they've not always got access to IT equipment, and they, you know, they maybe can't. There's recovery rules in place, if you like, to keep everybody safe in the recovery groups, and they maybe weren't there. So what we said was, do you fancy coming out for a walk? So what happened was then we ended up putting on a walk event every month because 15 to 20 people turned up, and I'll just show you the next slide on that. Does it move? All right. So there's so about 3 months in a row it's run, and it was as simple as, do you want to come for a walk? And we were just, Sean was just offering up one-to-ones with people, do you want to come? But actually everybody said yes. So we're like, right, let's just put an event on. And the BBV nurses come along to that as well, so we can catch up anybody who needs their second Hep B vaccination. Naloxone's routinely handed out, the mental health benefits that women say they get. And for some women, it's the only chance they can bring children along. It's the only time they're getting out of the house. We had a peer who was a volunteer before she fell pregnant, and now that she's had a baby, there's no chance of her getting out of the house for childcare despite having lots of services in place. She's not able to connect. So this is her one time a month where she's able to connect with peers. Okay, so my third and final one. This is, I'm talking a load of fish next. So here we go. I saw this online, and I always feel sorry for the people that have got to mainstream the work that I decide to start as well. So you'll hear from them next. But I saw this on my news feed that fishing was being prescribed to NHS in Manchester, and I thought, oh, that's a good idea, because lots of people can't come for a walk because of their mobility, even though our women's walk allows for all levels of mobility. But some people just aren't up for a walk. So within a week, I was speaking to people. We were dropping our phone off, and I said to a guy, fancy coming fishing? He was like, oh, I used to do fishing. I'll show you all how to fish. And then I told somebody else, went, oh, my cousin's got a fishery. And then I told somebody else, went, oh, I've got fishing rods to give you. And within a week, we had arranged to just go somewhere to a local spot and a group of people fishing. So the BBV nurses, Restoration, and maybe about 8 participants or something. But Nikki will talk more about that the next bit, because it's become a really oversubscribed group, if you like. And Fife's got a coastline, so you can easily pick some fishing spots. But yeah, we're getting more and more experts along that seem to know what they're doing. So anyway, we went locally, shopped local to start with, and we've been, it's been able to be mainstreamed, and Restoration's been able to generate income from local area committees because we're shopping local taxi hire, local amenities, local coffee shops, local fishing shops, local, so everything's sort of staying local on top of the fact that people are getting out of the house. It's an opportunity for them to test a wee bit of group work and what it's like, and it doesn't sound totally invasive if you're saying to somebody, just come along, I'll take you fishing. It's way better than trying to send somebody to some sort of recovery community or another service or something that feels just like it's another load of rules and another person to be involved in their life when they could just simply come fishing. And that's, I think, been the success of the fishing groups.
Thanks for that, Louise. Like I said, it's just so inspirational. Love it. I'm going to introduce Nikki Smith now. Nikki's from Restoration, and she's going to be talking about their bloodborne virus peer navigator programme.
Well, hi everybody. So I'm Nikki. I'm Restoration of manager of Restoration. So we're going to play a wee video from our co-founder and chair, Shannara. Now the video has got a couple of seconds of sound issues at the start, so you might need to adjust your volume, but hopefully it'll be okay. So I don't know if you want to start the video just now, and then I'll chat about project after that. But yeah, start that now.
So Restoration was founded in 2011, and we were a group of people who were a community who put on activities and events free from substances and safe for families, providing for people who could feel ownership over that space. Nearly 10 years later, COVID hit. Restoration had been providing community and peer support, as well as fun and interesting opportunities for people to try new things. This included providing health checks. It provided a bit of testing, alternative therapies, lots of relaxation techniques and meditation and sports, and just lots of things to improve people's well-being overall. Then we couldn't meet as groups anymore. That changed everything. We began to increase the amount of aggressive outreach we were doing, so that way our cohort, who were generally quite isolated and lonely individuals, were not meant to left isolated. It required that we had to change what we did. We had to move from everything being groups, everything being in person, to everything that was online. We introduced people to technology. We had to help them with their literacy, but we also discovered that there were a lot of needs that weren't being met. Because we are small and nimble, we have a model that allows us to quickly respond to things, use out-of-the-box thinking, and we have really low overheads. This meant that small grants could be squeezed to go really quite far with us. And we were also able to implement some tests of change that other places were asking for, particularly health services were asking for a bit of support, getting hard to reach clients due to our lack of bureaucratic structures. One of the tests of change is stroke partnership that we were in included meeting up with marginalised people around Fife who health providers identified, but also homelessness workers, addiction services, nurses, and also just pounding the pavements ourselves, getting to know the folks who we saw on the streets, asking them how they were. These folks were provided with things that they deemed to be most necessary in their life at the moment. That included appropriate food, so it might be that people had dietary issues, or that they just didn't like something, or they were in temporary accommodation that didn't have any cooking facilities, they didn't have a kettle, but they had a microwave. So listening to what their needs were. Utility top-ups, mobile phones, because you could not access the doctor, the dentist, the job centre, social work, literally any service without a phone. Top-ups, because you might not have the income to then keep the phone up and running. Referrals to other services, our local addiction services, health services, but also sometimes just a bit of human contact. Hi, how are you? What matters to me right now is just having a connection. was invited to bid for a tender to support people in Fife living with bloodborne viruses. This was to match up with the lifestyle support that a patient would need in order to undertake or maintain treatment for HIV or hepatitis C. Our bid spoke about treating people with simple human kindness and dignity, meeting the needs that the people see that they need or that they want, not necessarily what the priorities were that were put together by a policy or a protocol. We wanted people to be seen to be people and to be treated as people and not as whatever their illness or their diagnosis is. So we wanted to provide opportunities for them to make friends or to ignore the world, depending upon what's right for them. To have food and safe, appropriate housing, conversations with a safe person, but also maybe just the carpet on their floor. Maybe they just have a bare floor and that's the most important thing for them. Maybe they just can't get over the mountain of dishes that need done and want to be hand sorting that out. Or clearing the rubbish that they've been hoarding up since they've been afraid to leave the house for a year. Clinicians know that clearing a virus that isn't drastically impacting somebody's day-to-day life, but might maybe kill you one day, isn't a priority when you have to worry about homeschooling your kid or when you have to deal with mental illness. So we're coming in to provide some of that just rest of life support in order to support the treatment. We also play a huge part in regards to the elimination of Hep C in Scotland. We always have. We have been a part of promoting good self-care in regards to getting tested for whether it's dry blood spot testing. We've encouraged all of our members to go along to that over the years, or whether it's getting Aura Quick just to set their minds at ease, or just being around, hearing messages day in, day out, and knowing that actually maybe I'm at the point where I'm ready to be tested, just to set my mind at ease, because maybe I did something risky in the 90s and I've never really wanted to face that. So we play a huge part in achieving the goal of elimination of Hep C in Fife, as well as the rest of Scotland, in that we have the patience to offer people many opportunities to slowly reduce the barriers they face in getting treatment, clearing the virus and living normal lives. Alongside the niche targeted work that we've just started doing, we also have a cohort of men and women who are in the age range to have been high risk for Hep C, who've never been tested. As I said, there might be lots of reasons they've just never felt comfortable or ready to be tested. So as we have in the past, we'll continue to offer testing, giving lots of opportunities to extend testing and then treatment. Since treatment is now not a big deal, it's not interferon, and that's the other thing, we're passing that information on. It's not scary to clear your Hep C anymore. And we want to catch those lingering cases and eliminate the virus once and for all, so it's gone. It's just gone. And allowing all of our members' recoveries to be as holistic and helpful as possible.
So you'll notice on here, if everyone can see the screen, this is an example of just a week out of Restoration's calendar. So we have monthly calendars, and we've got such a big range of online, face-to-face, indoor and outdoor activities. It's very much peer-led, so a lot of the ideas come from members who attend the group. We have like art classes, cafes, cooking, women's, men's groups. We have walks, we even have dog walks, so you can bring your kids, your dogs, whatever you want. We have cinema, we have bingo, quiz, music nights and outings, so there's something for everyone. But one of the things I want to highlight with Restoration is that we are very low threshold access. So that means there's no referral forms to fill out, which I'm sure is music to some people's ears. You can literally just get people to call, text, WhatsApp, PM us on social media, email, whatever's easier for staff and individuals to get people access and to support straight away. We will support people on it based on their individual needs. And it's one of our priorities that people can access support with little barriers as possible. So post-COVID, we had monthly Hep C health sessions at our recovery cafes, and we did that in partnership with the NHS BBV team. where people could get tested and access treatment. We worked in partnership with SDF on Hep C events, again for people to get tested, and this is something Restoration has been part of and pretty much promoted for the 10 years it's existed. Obviously when COVID hit, or landed or arrived, whatever way we want to say it, Restoration really had to up its outreach support and work in partnership with services who we already had long-standing partnerships with. But they were really reaching out to us, knowing that we would provide an immediate response to those needing crisis or basic needs support. We have, I mean, this is only a week of sort of what we do, but, you know, you might, I don't know, you'll maybe think, you know, this must cost a fortune to run. But Restoration literally have been able to run on a shoestring budget, not because we wanted to, but we've had to. But with close partnerships and community connections with various organisations and people, we've always been able to manage this very effectively. Good thing about being a community organisation is we have less red tape to worry about, and we identify something, when we identify something needs to happen, we just will pull together and make it happen. We're like a big Resto family. Our members are always involved and willing to help out as well. So from planning to delivering and evaluating, we get people involved in everything that we do. But most importantly, we all have loads of fun. People get a chance to meet new people, meeting others who have similar experiences and can support them. 80% of our staff team have lived experience, and peers have always been a huge part of what we do, and their experience and support to peers within this project has been invaluable. So I know, Louise, you had mentioned about this, about the fishing group, and that's, I think, a great example of, you know, when the team went out to visit someone on a home visit, part of the conversation, as well as, you know, crisis support, and was about, you know, what would help you get out the house. You know, just having that chat, what interests, hobbies, and it turned out in a passion for fishing. So that was it. It was a case of, right, well, let's go and get some fishing rods and make it happen. And now we're actually having to limit attendance. It's become really popular. So, but I hope that gives you a kind of idea of what we do at Restoration. I'm not going to repeat too much of what Louise and Shanana have said, but if you want to know any more about Restoration, or you've got any more questions, then please feel free to ask me, guys, in case I've missed anything out. That's it.
Thank you so much, Nikki, and thanks to the lovely Shanana and Louise. Restoration, I just have so much respect for. I've seen the difference that Restoration make to people's lives. I've seen it firsthand, and it's really, really humbling. They get their sleeves rolled up and they get on with it. Yeah, really, really inspirational. So that's kind of bringing us near enough to the end of the conference, the event now. Yeah, Hepatitis Can't Wait. The message is loud and clear, and the people that have spoken and presented today absolutely epitomise that message. They're out there and they're doing it. If you're not kind of involved in doing anything, hopefully you may have found some inspiration. Or if you are doing things, or you're aware of people that are doing things, what we're hoping is that you'll be able to share that with us. The reason that we had the event on the 21st rather than on World Hepatitis Day itself is that we're hoping that people will be out and about there. I know certainly my team want to be out on the front line on World Hepatitis Day. We would love it if you could upload any footage, any TikTok, any content at all of anything that's happening in and around World Hepatitis Day. Please share it with us, and we will get that reposted and distributed so that people can really get a sense of what is going on out there. That would be really, really appreciated. Lastly, I just want to say a massive thank you to the people that have come along today. I hope you found something that you can take away from it, and I hope, you know, I hope you'll take away the message that hepatitis can't wait. And what will you do? What will you do next to kind of contribute to that?
Just to thank everybody, I want to say a massive thank you to everybody that's contributed, the Fife bloodborne virus nurses, Karen, Stacey, Karina and Anne, and our TikTok star Jodie, the EpPIToPE team, Petra, Jim wasn't present but here in spirit with us, Lesley, Louise, Billy and Eddie, Shanana, Nikki, the rest of the team, and finally a massive thanks to Sophie Milton. I think I've driven her mad the last month, but she has really pulled all this together and behind the scenes made it happen. So I'll say thank you again and take care everybody. Bye bye.